Good afternoon. This is a continuation of the class. We're going to review the group presentation of anxiety and depression, and then we'll continue the topic for central nervous system. Okay, so anxiety and depression. Basically, you know that everyone periodically experiences anxiety. Um, Basically, it's a physical, it's behavioral response to an immediate recognized external threat. Anxiety is also distressing, unpleasant emotional states of nervous and uneasiness. Some degree of anxiety is adaptive, and it can help people prepare, practice, and rehearse so that their functioning is improved and can help them appropriately cautious in potential dangerous situation. However, beyond a certain level, anxiety causes dysfunction and undue distress. So at this point, it's not adaptive anymore. It will be maladaptive and is considered an anxiety disorder. So anxiety depression basically results from the interaction of the central, peripheral, endocrine, genetic, and environmental factors. It could occur in a wide range of physical and mental disorder, but it is the predominant symptom of several. Anxiety disorder are more common than any other class of psychiatric disorder. However, they often are not recognized and, of course, not treated properly. And when anxiety is untreated, then chronic maladaptive anxiety can contribute to medical disorders. So anxiety and depression involves cerebral cortex, frontal, temporal lobes, basal limbic system, hippocampus, amygdala, etc. In the hypothalamus, since the hypothalamus maintain endocrine function, appetite, sleep, wakefulness, you're going to see all these symptoms associated with anxiety. So basically, the etiology is unknown, but both psychiatric and general medical factors are involved. Many people develop anxiety disorder when sometimes the antecedent trigger is not able to be identified, or sometimes you actually know what it is. For example, an incoming family member or uh, an exam, etc. So anxiety can be a response to environmental stressors such as ending significant relationship or exposure to a life-threatening disaster. Um, Now, it's very important that you need to be able to rule out before you label a patient with anxiety or depression um, certain medical disorders. So, hyperthyroidism. Whenever a patient comes with anxiety symptoms, you have to do a TSH, T3, and T4 to be able to rule that out. Pheochromocytoma, if you remember, this is a benign tumor of the adrenal medulla where all the catecholamines are released. So having a tumor patient would have paroxysmal hypertension associated with signs and symptoms of anxiety. I'm not saying that you're going to be doing a CAT scan of the abdomen to everybody, but that's a disease process that you have to have in mind. Arrhythmias such as sinus tachycardia and AFib and flutter, patients would have symptoms associated with anxiety. Asthma has a psychological component, so patients also could come with anxiety disorder associated with this disease. Depression as well, instead of hyperthyroidism, will be hypothyroidism. So you need to be able to rule out hypothyroidism and hyperthyroidism before you label a patient with depression or anxiety. If you remember anatomy and physiology, the frontal lobe basically executes control and personality, also express emotions and decision making. The diencephalon relays on motor input and output, and the hippocampus and amygdala basically is memory, learning, and formation of emotion. All this will be affected in anxiety and depression. So we already talked about this serotonin and dopaminergic pathway when we started discussing cholinergics and anticholinergics. And also, if you remember, dopamine pathway is basically in control of reward, pleasure, euphoria, compulsion, and perseveration. And serotonin pathway is in charge of mood, memory, sleep, and cognition. So the signs and symptoms of anxiety, before we go into the medications, they can arise suddenly as panic or gradually over minutes, hour, or even days. May last for a few seconds to a year. It could range from barely noticeable uh, symptoms up to panic attack. So the ability to tolerate a given level of anxiety varies with person to person. Can be distressing, disrupting, and also may coexist with depression. And knowing that all these neurotransmitters would be affected in anxiety, such as serotonin, GABA, and dopamine, basically is what we will trigger with medications for anxiety and depression. So we'll be using pharmacological action on serotonergics, GABAergics, and dopaminergics. The majority act at the level of the reuptake of serotonin, as well as GABA, which is an inhibitory neurotransmitter, and also enhancing an excitatory neurotransmitter, which is dopamine. If you remember, GABA has a depressing or slow down neurotransmission, so that would reduce anxiety. Serotonin has a calming effect. Um, if you recall here, it would improve mood, memory, sleep, and cognition. So all the signs and symptoms of depression. And dopaminergic also has an anxiolytic effect. To be able to diagnose the anxiety and depression, you have to, this is important, you have to exclude other medical causes, as we already mentioned. So, and also assess severity. So when other causes are not identified, um, you could say that the patient most likely has anxiety. In addition, you will go through a semester of mental behavioral disorders, which you would learn the fifth edition of the Manual for Mental Disorder and Diagnostic Statistics, which is a DSM, which basically describes the specific symptoms and requires exclusion of other causes and symptoms. Family history of anxiety disorder helps in making the diagnosis because some patients appear to inherit and are predisposed more to anxiety and depression than others. Treatments, as you would see, basically vary from the different types of anxiety, but typically involve combination of psychotherapy and a specific drug, which will include the most common categories, which are SSRIs and benzodiazepines. I'm not going to go over the different types of anxiety disorders. You're going to have a whole semester for that. But the anxiety disorders are basically generalized anxiety disorder, panic attack, phobic disorders, agoraphobia, social phobia, also PTSD, which is post-traumatic stress disorder, acute stress disorder, etc. Now let's go over the categories of the treatment of anxiety and depression. We will discuss the non-selective norepinephrine serotonin reuptake inhibitors, which are the TCA, not commonly used. Basically, it's the second line after the selective serotonin reuptake inhibitors. And also at the end, monoamino oxidase inhibitors only when patient is refractory to all of the above. And also we will discuss the GABAergic receptors, the enhancers, which are the benzodiazepines for anxiety. So you would see that the majority will target either norepinephrine or serotonin or dopamine. And at the end, for anxiety would be basically GABA enhancers, which, remember, GABA is an inhibitory neurotransmitter. But of course, since the pathophysiology of major depression is mostly emphasized on serotonin, the lack of serotonin or decreased levels of serotonin receptors, you would like to start treatment with the most selective serotonin reuptake inhibitor drug category. So we'll start with non-selective, and the prototype drug for the non-selective norepinephrine serotonin reuptake inhibitor or TCA or tricyclic, which is also called, is amitriptyline. We also have nortriptyline, imipramine, doxepine, etc. So before going into the medications specifically, let's review what the group discussed about major depression. Patients with major depression, you know that they appear miserable with tearing, with slump posture, poor eye contact, lack of facial expression, soft voice. They basically talk in monosyllabi. Rarely they make sentences. They appear sometimes confused, and that's when you have to rule out possibility of Parkinson disease or dementia in the elderly population. They are nutritionally impaired because they don't eat properly. Some depressed patients even have neglect personal hygiene, and even children and their pets. The most important thing is that for diagnosis of depression, you need more uh, or equal to 5 of the following symptoms, and they must appear every day during the same 2-week period to be able to be classified as depression. Just because you have these symptoms one day because you failed class or you did poorly on grades, that doesn't label you as depression. You need to have 5 consecutive symptoms or more for the 2 consecutive weeks every day. So that would be depressed mood most of the day, markedly diminished interest or pleasure in all activities, significant weight gain or loss or decrease or increased appetite. So changes in weight and changes in eating habits. Insomnia, which most likely the difference in insomnia between anxiety and depression is that the anxiety patient is unable to fall asleep, but once they fall asleep, they sleep through the night. The depressive patient, they fall asleep quickly, but they have breakthrough insomnic episodes through the night. So that classifies patient with anxiety with insomnia and depression with hypersomnia. They could also have psychomotor agitation or retardation, fatigue, loss of energy, feeling of worthlessness, having excessive or inappropriate guilt, diminished ability to think or concentrate. They're constantly on the side. They have recurrent thoughts of death or suicide or even suicidal attempt, or even they have a specific plan for committing suicide. So having these symptoms classify a patient with depression. So let's continue with the medications that we could use for depression. So for monoamino oxidase inhibitors, we have the prototype, which is phenethylamine, SSRIs, fluoxetine Paxil, and fluoxetine. We can also use paroxetine, which is Paxil, sertraline, which is Zoloft. In addition, we could use serotonin-norepinephrine reuptake inhibitors, which the prototype here will be the valanzamine Effexor, but we have many more in the market, such as Cymbalta, for example. Now, all of these medications, as I said, they basically inhibit the reuptake of catecholamines. Which catecholamines? Really depending, because for example, TCA, if you go back, is non-selective, so they will be reuptaking norepinephrine and serotonin at the level of the postsynapses. If we go into monoamino oxidase, basically will be norepinephrine and dopamine. Selective serotonin will be only serotonin. Serotonin norepinephrine would be both serotonin and norepinephrine. So basically what they do, all of it, they inhibit the reuptake of amines, which are the alpha or beta catecholamines at the level of the presynapses. In this case, again, norepinephrine, serotonin, or dopamine. For TCA, again will be norepinephrine and serotonin. They basically also downregulate beta receptors at the level of the limbic system, so they could be used as mood stabilizers. The neurotransmitters, again, basically tricyclic antidepressants. They inhibit norepinephrine synapses as well as serotonin synapses. They also inhibit histamine as well as acetylcholine. So you have to be very careful because patients with TCA antidepressants, they could have drowsiness and weight gain associated with histamine blocking, and also all the signs and symptoms of nicotinic, which is an anticholinergic effect, which is everything dry and everything fast, and also mydriasis being contraindicated for patients that have glaucoma. In addition, due to the alpha adrenergic blocking effect that TCAs have on the myocardium, you have to be very careful when you prescribe these medications to patients that have cardiovascular diseases, because they can go into severe cardiac arrest as well as cardiac arrhythmias. Now, talking about non-selective norepinephrine reuptake inhibitors, we have again imipramine, tofranil, desipramine, norpramine, amitriptyline, Elabil, and doxepin Sinequan. Now, again, basically being imipramine, tofranil, the prototype. Remember, yes, it's used for anxiety disorders because they also block norepinephrine, but they also use for neuropathic pains for patients that have nocturnal enuresis. Since they act, again, at the level of the neurotransmitter serotonin, as well as norepinephrine, they also could block histamine and acetylcholine. So as previously stated, very, very important on the anticholinergic effect to be careful with glaucoma, prostate hypertrophy, and urinary incontinence. And in addition, due to the alpha blocking effect, you have to be very careful with patients that have myocardial problems. So recent MIs, acute CHF, patients with cardiac arrhythmias, so patients that have declined inotropic function, and also cardiac conduction, because they slow depolarization at the level of the cardiac muscle, contributing to prolongation of QRS complexes and also QT interval. So this is the reason why it is very important when the patients are on TCAs to monitor the EKG baseline before starting treatment. Half-life is 6 to 18 hours, and major adverse effects we already stated. So because it has a sedative effect, so patients would have, with all the antidepressants and anxiolytics, they would have sedation, drowsiness, they could have hypotension due to the alpha blocking effect, they could have everything dry and everything fast, and also mydriasis due to the anticholinergic effect, which is the nicotinic effect. So again, be very careful with patients that have glaucoma. This is already stated. Now, how do you educate? Never, never, any antidepressant could be discontinued abruptly. Now, to be able to work, remember that you need to allow at least 6 to 8 weeks for any antidepressant to take effect because of the long half-life that they have, and also they need that for steady state. Avoid over-the-counter medications that could also increase the catecholamine effect, such as many cold remedies could do that. In addition, as I said, since the TCAs have a quinine-like effect, they could produce cardiac arrhythmias and heart blocks, as well. So try to monitor EKG. Remember the QT and the QRS interval because it's low depolarization. You should monitor that as well. In addition, remember, because of the anticholinergic effect, glaucoma must be assessed. So the patient must report any signs and symptoms of cardiopulmonary process, such as shortness of breath, such as chest pain, irregular rhythm, etc. All antidepressants will increase, all of them have a black box warning of a suicidal attempt, because they do, even though they treat depression, it's kind of paradoxical. Even though they treat depression, they have a high risk of suicidal ideation and attempt. Now, let's go through monoamine oxidase inhibitors. Basically, these medications, what they do is that they inhibit monoamine oxidase, which is an enzyme that acts on the neurotransmitters that we already mentioned, such as dopamine, norepinephrine, epinephrine, and serotonin. In addition, they prevent the breakdown of thiamine. So this is very important for practice and your exam, that patients with monoamine oxidase inhibitors, they should not be taking diet or ingesting food that contain thiamine, which is basically fermented products, such as aged cheese, yogurt, sour cream, alcohol beverages, some chocolate, soys, sauce, fava beans, avocados, chocolate, ginseng, etc. So avoid that, because the problem is that the patients could go into hypertensive crisis, since thiamine is a precursor of dopamine, norepinephrine, and epinephrine, and the MAO inhibitors prevent the breakdown on thiamine. Patients would have more dopamine, more norepinephrine, more epinephrine, which are catecholamines. What they do is produce palpitations, tachycardia, and hypertension. So patients could go into hypertensive crisis, which you have to educate the patients of signs and symptoms of hypertensive crisis, which are mainly palpitations, tachycardia, chest pain, sweating, headache, etc. And when this is diagnosed or suspected, patients are usually treated with phentolamine, which is an alpha blocker. So it's never used as the first line treatment, not even second. MAO inhibitors are reserved for the treatment of refractory depression, when none of the antidepressant medications have worked. So it has many drug interactions because of cytochrome P450 interaction. They could produce diarrhea, yes, headache, etc. But you should not forget the hypertensive crisis due to food containing thiamine products. This is basically the explanation why MAO inhibitors work for depression. Basically, they inhibit the destruction of norepinephrine and serotonin, allowing more neurotransmitters to remain active at the level of the synapses. So that's what reuptake means. So basically, they inactivate the enzyme that metabolize norepinephrine, serotonin, and dopamine. As I told you, prevent breakdown of thiamine found on aged foods, conserved foods that I already mentioned. They do have a very high first pass effect, having a lot of interactions. So what are the major side effects? You cannot forget hypertensive crisis. In addition, of course, all the antidepressive medications, that they would have depressive symptoms such as insomnia, they would have lethargy, they would have daytime sleepiness, But in addition, remember they also have alpha blocker activity, they also have antihistamine activity, they all have anticholinergic activities when they're not selective serotonin. So they would have dryness, dry mouth. They could have everything fast, psychological jittering, nervousness, agitation, up to even seizures, because TCAs decrease the threshold for seizures. So because even though it's cheap and for pharmacoeconomic, should be one of the most prescribed medications. It has many adverse effects and dangers, including cardiovascular disorders. So this is the reason why it's never ever the first choice of treatment. Now let's talk about the most important and first line treatment for depression and anxiety, which is the selective serotonin reuptake inhibitors. And that includes the Prozac, paroxetine Paxil, sertraline, Zoloft, fluvoxamine, Luvox, citalopram, Celexa, and escitalopram, Lexapro. They're the most commonly used, and they selectively block the serotonin receptors, making them more available at the level of the postsynapses. Your prototype would be your Paxil and the sertraline Zoloft, but again, they're more as we already mentioned. So let's take Paxil and Zoloft as your prototype. All of them, they selectively inhibit the reuptake of serotonin at the level of the presynapses. They do have a minimal, that's why it's called selectively, minimal effect on norepinephrine and dopamine. Of course, side effects will be related to those two, but again, it's the one that has the least of the side effects. So it has a very slow absorption and a very long half-life. This is the reason why the majority of the antidepressants need at least 6 to 8 weeks to work. They have a very extensive pathway through the liver. First, hepatic metabolism involving cytochrome P450. They all have high risk of suicidal attempt. They all have high risk of sexual dysfunction, as mentioned in TCA. In addition, of course, because they're medications that could alter the CNS, patients could have from lightheadedness to dizziness to sweating, and even sometimes exacerbation of anxiety. But do not forget that because they do act also at the level of the dopamine, histamine, norepinephrine, and acetylcholine, even though it's less than the others, they could have as well dry mouth and all the signs and symptoms of anticholinergic effect. Now, of course, in all the antidepressant medications, you have to be very attentive for suicidal ideation. Avoid over-the-counter medications that increase serotonin and norepinephrine. Avoid alcohol. Try to tell the patient to adhere to the medication because it doesn't work right away. What you need to be aware of is serotonin syndrome. That you must know. And that basically is a life-threatening situation, which basically there is interaction of medications or even herbal drugs that increase the amount of serotonin. So it's basically categorized as an overdose. It's excessive level of serotonin produced by medications and interactions with other drugs that produce cognitive, autonomic, and somatic effect, as we said in class. Basically, patients will have increased heart rate, shivering, sweating, dilated pupils, myoclonus, hyperreflexia, jerking and twitching. They would have tremors. They would have high blood pressure, hyperthermia, and this hyperthermia will be over 104 Fahrenheit or over 40 centigrades. They would have hypervigilance, insomnia. They could go into rigidity, rhabdomyolysis, leading to renal failure, even leading to seizure, metabolic acidosis, and disseminated intravascular coagulation. So the majority of the symptoms will be related to cognitive, autonomic, and somatic effect, as is stated here. The cause, as we already stated, we're talking about antidepressants. So combination of any antidepressants could lead to accumulation of serotonin at the level of the synapses and produce serotonin syndrome. But that's not the only medication that could produce that. So opioids could do it, mostly hydrocodone, fentanyl, CNS stimulants, because basically they go through the same mechanism of action, such as amphetamines, cocaine could do it, any type of Phenergan, for example, could do it. For migraine, the 5-HT, which are serotonin agonists, the triptans, could do that as well. Many herbs, as I stated in class, such as ginseng, Sanjong wort. In addition, Cybox is an antibiotic that could produce serotonin syndrome because it's basically a family of a TCA. Risperdal, many antipsychotic medications, even metoclopramide, which is an anticholinergic, antiviral medication, so levodopa for Parkinson. So this is not the only group of medication that could produce serotonin syndrome. So before we go into this, you must be able to recognize the symptoms of serotonin syndrome for your exam. And how do you manage? Basically, you have to give a serotonin antagonist, which is cyproheptadine, which is periactin, ataract, is basically an antihistamine medication. Okay? Very, very similar to neuroleptic malignant syndrome, as we will discuss in a little bit. So for serotonin-norepinephrine reuptake inhibitors, we have other group that is Cymbalta, for example, and Effexor. They work for major depression disorder, generalized anxiety disorder, in addition for fibromyalgia, neuropathic pain. Remember, antidepressant medications, neuroleptics, is one of the treatments for pain, and that pain is mostly neuropathic pain. So they're considered a typical antidepressant, and what they do basically is inhibit the reuptake of both norepinephrine and serotonin. All of them is not only this group. Remember, they have an alpha-2 blocker effect, they have an anticholinergic effect, and they have an antihistamine effect. So therefore, try to avoid them in patients that have cardiovascular disorders and as well as narrow angle glaucoma. They all have a high cytochrome P450 activation, so a lot of drug interactions, and the side effects will be basically the same. So dizziness, insomnia, dry mouth for anticholinergic effect, hypotension, as well as sometimes hypertension, but mostly the MAO inhibitors will do that. Suicidal ideation, in all of them you have to avoid over-the-counter medication. In all of them you have to check EKGs, you have to check BUN and creatinine, you have to check LFTs. Now, what's the recommended treatment for depression? The first line treatment would be always your SSRIs, and that would be your prototypes, which are the fluoxetine and Dantrolene. Second line, tricyclics, and third line, atypical antidepressants. If you look here, never is mentioned the MAO inhibitors. In addition, you could use complementary therapy, but remember, even though Sanjong worts could be used as an adjuvant of treatment, you have to watch for signs and symptoms of serotonin syndrome. Now, there's a theory also that depression is associated with low folate levels, so you could supply the patient with it as well as omega-3. Now let's talk about psychosis and schizophrenia, which I gave a brief introduction in class. So basically it's loss of contact with reality. Patients would have hallucination, which are false perceptions, delusions, which are false beliefs. They will have disorganized speech and behavior. They would have flattened affect. They would have cognitive deficit with impaired reasoning and proper solving a problem. Basically, the cause is unknown, but it's a disruptive mental state in which the individuals struggle to distinguish between the external world, actual reality, and their perceptions. Now, psychotropic agents that we will use for schizophrenia and atypical psychosis not only treat those, but also treat schizoaffective disorder. They treat mania and acute manic phase. They also treat delusional disorders. They also treat Tourette syndrome and Huntington chorea, as I explained in class. In addition, I also explained in class that we do have a dopaminergic receptor at the level of the internal ear that psychotropic medications could be used for the treatment of MSs associated with it. So symptoms of schizophrenia usually begin in adolescence or early adulthood. It's actually said that if you're 35 years of age and you have not developed signs and symptoms of schizophrenia, you're never going to be schizophrenic. One or more episode of symptoms must last more than 6 months before the diagnosis is made. And basically, the signs and symptoms would be positive and negative, as we discussed in class. So the positives mainly would be the hallucinations and delusions, and the negative will be mostly loss of normal function, disorganized thoughts, bizarre behavior, isolation, the paranoia, etc. So since the major pathophysiology of schizophrenia is basically having too much dopamine, what we will do is basically block the dopamine receptors at the level of the hypothalamus, the basal ganglia, the limbic system, the brainstem, and the medulla. And because we do block these receptors at the level of the hypothalamus, you would see CNS disorders associated as side effect. Basal ganglia, remember, that controls fine motor coordination and cognition, so you would see side effects related to that, which will be mainly related to Parkinson's disease. Limbic system will be mostly mood and affect, so you would see side effects associated with that as well. So we have the first generation and we have the second generation. First generation, very, very old, used, and of course has more side effects. Those are your thorazine, prolixin, haldol, of course, will be your prototype. But in addition, there is Serentil and Melaril, etc. So remember, they basically what they do is antagonize dopamine receptors. And I gave the explanation of prolactinemia in class as well. So they not only block dopamine, but by blocking dopamine, they have an anticholinergic activity. So you would have all the signs and symptoms of nicotinic activation, which is the anticholinergic effect, everything dry, everything fast. In addition, there's an alpha adrenergic effect, mostly alpha 2, so patients will go into orthostasis, hypotension. They actually also antagonize histamine, giving you drowsiness and weight gain, neuroendocrine disorders, as well as lower seizure threshold. Now, the typical antipsychotics that we already mentioned in class, there are thorazine, your prototype, and non-phenothiazine, which is haldol, your prototype as well. And the atypical antipsychotics, even though there are many, Risperdal will be your prototype. So basically, all of them block dopamine receptors at the level of the basal ganglia and more. And the major side effects for this will be the Parkinson uh, signs and symptoms, and associated with elevation of prolactin levels, so having gynecomastia and having galactorrhea. In addition, the extrapyramidal symptoms that will be present, that we already discussed in class, that you could treat with cogentin and also Benadryl. So these are the extrapyramidal symptoms that you must recognize to be able to discontinue the drug or reduce the dosage and give cogentin. So the dystonia, the oculogyris crisis, Parkinson signs and symptoms, akathisia, and also as well as tardive dyskinesia. So basically they're given for patients that have atypical psychosis and schizophrenia. Be very careful with the elderly population since they tend to have most of the side effects. Now let's talk about neuroleptic malignant syndrome. And this basically is more or less very similar to serotonin syndrome. It's a life-threatening neurological disorder also caused by neuroleptics and antipsychotic drugs. So patients go into autonomic instability, muscle rigidity, fever. They go into delirium. They go into elevation of CK, rhabdomyolysis, metabolic acidosis, renal failure, etc. And of course, you would also see signs and symptoms of Parkinson disease associated. Patients could go into hypertensive crisis. They could go into cardiac arrhythmias and even death. And one of the main categories for classification of neuroleptic malignant syndrome, the patient must have a temperature greater than 100.4 or greater than 38. They should be confused, diaphoretic, have rigid muscles, and also autonomic instability. All the symptoms mentioned in this slide. So basically, how do you treat? The malignant hyperthermia could be treated with Dantrolene, which we'll discuss here. Is basically a muscle relaxant to reduce muscle rigidity. Also, in addition, you could use dopamine pathway medications such as bromocriptine that we'll discuss in Parkinson. Amantadine is another option that patients could get as dopaminergic and anticholinergic. In addition, for patients that have seizures, benzodiazepines will control agitation as well as the seizure episode. So let's talk about the muscle relaxants. And we do have the baclofen and as well as carisoprodol, Zoma. We do have the Flexeril, and even though the mechanism of action is not well understood, basically they act centrally at the level of the alpha-2 adrenergic agonist to produce inhibition of the motor neurons in the spinal cord, reducing muscle spasticity. In addition, they act basically not at the level of the muscle, but at the level of the synaptic reflex arch. So they treat spasticity with the patients that have open motor neuron. They disrupt the release of calcium. Of course, you need calcium for the sarcoplasm, for the actin on the myosin to be able to contract. So inhibiting release of calcium would produce muscle relaxation. And diseases that could be treated for that would be spinal cord injury, neuroleptic malignant syndrome, as we already mentioned, malignant hyperthermia, cerebral palsy, and patients with multiple sclerosis. Now, in addition, it's very important to notice that one of the medications that are used before we go into Botox for muscle relaxation is Flexeril. Flexeril it does affect the thyroid, putting the patient into either hyper or hypothyroidism. But if the patient do have hyperthyroidism, because of the alpha blocking effect, patients could go into conduction disturbances and arrhythmias, when they are in recovery of myocardial infarction and heart failure. So even though we use Flexeril a lot, patients could have cardiac dysrhythmias due to too much muscle relaxation, mostly bradyarrhythmias and asystole. Um, and also, this is the reason why it's contraindicated in patients that they're in the acute recovery phase of myocardial infarction, because you need that pumping activity. In addition, remember all of this, they also have an anticholinergic effect, so you have to be very careful with glaucoma. They could produce anaphylaxis and angioedema. Um, you have to watch renal function. Um, Flexeril is another medication, even though you don't need to memorize this, that could produce serotonin syndrome. So because they do activate serotoninergic pathway, they could produce paralysis. Um, Botox is basically used for patients that have hyperhidrosis because they produce a denervation of the sweat glands. Muscle paralysis, so is basically used for patients that need to block neuromuscular transmission, uh, for the trusor muscle, to inhibit acetylcholine release when patients have um, overactive bladder. Um, so again, they block neuromuscular transmission. Um, they also temporarily decrease the innervation of the sweat glands, so that's for hyperhidrosis, and to paralyze the detrusor muscle in patients with overactive bladder. Botox is also used for strabism, is also used for achalasia, so it does have many, many indications. Now, let's talk about, even though it should not be here, this slide was supposed to be related to antipsychotic medications, so I do apologize. So remember, patients with psychosis, they do have in their pathophysiology too much dopamine, and their mechanism of action of medications to treat this condition is to block dopamine. So therefore, they do have Parkinson side effects, such as what you already know: the stiff stoop posture, the mask-like face, the shuffling gait, the cogwheel rigidity, drooling, tremor, bradycardia, the pill rolling movement of the thumbs and the fingers, in addition to, of course, EPS syndrome. This is a study that was done that is best to combine thorazine and stelazine for patients that have refractory um, psychosis and depression, for as tranquilizer treatment, for patients who have ceased to progress on a single tranquilizer, or patients that have side effects, major side effects with high dose of these medications, etc. So they suggest a combination of thorazine and stelazine for severely psychotic patients when you want fast results. Now, antipsychotic medications that could be used for major side effects, as I mentioned, you could use Cogentin and Benadryl for the symptoms of EPS, as well as Tenolol for the tachycardic effects. You could use as well amantadine for the dopaminergic blocking effect, and a pseudoparkinson disease. Now, talking about Parkinson disease, if you remember in pathophysiology, Parkinson disease is basically having slowly progressive degenerative disorder that produces resting tremor, stiffness, bradykinesia, and all the symptoms that we just discussed right now. Um, Diagnosis is mainly clinical, and the treatment is basically made to restore dopamine function in the brain with levodopa plus carbidopa, um, As well, you could use dopaminergic agonist, or you could use type B MAO, which are amantadine. Now, having going back a little bit on the pathophysiology, remember that basically is not having enough dopamine at the level of the basal ganglia and the substantia nigra. Um, in addition, there is another theory that there is an excitatory signal of acetylcholine. In addition, there is Lewis bodies at the level of the nigrostriatal system that produces all these symptoms. Um, in the substantia nigra and the leucocerulo, there is the depletion of dopamine, um, producing all these manifestations, motor mainly, at the level of the dorsal aspect of the basal ganglia. It could be a genetic disorder, mostly, but it could be also environmental factors. This is the effect that dopamine produces at the level of the motor cortex, um, producing all the signs and symptoms of increased muscle tension and tremor associated with the inhibition of acetylcholine at the level of the basal ganglia, uh, diminishing the levels of dopamine. So basically, what all these drugs produce is to increase the level of dopamine and acetylcholine at the level of the substantia nigra and the corpus striatum, as we already stated. First line treatment for Parkinson disease is levodopa, carbidopa, but what they do have as a major problem is the on and on phenomenon, in which basically the symptoms suddenly worsen or improve um, of Parkinson associated with it. So that's the reason why it's given as a combination. In addition, you could use amantadine, you could use Simetrel, you could use Requip, etc. Sorry. Now, dopaminergic drugs that could be used for Parkinson disease would be levodopa carbidopa, which is Sinemet. Basically, what it does is inhibit the breakdown of levodopa in the periphery, and those antagonize the carboxylase, and having more dopamine at the level of the central, at the level of the synapses, and is a precursor of dopamine. Um, Dopamine agonist, we could use bromocriptine, parlodel. Basically, what it does is stimulate the dopamine D1 receptors and inhibit the reuptake of dopamine. It's not only used for Parkinson disease, but it's also used um, in restless leg syndrome and bipolar disorder. The bromocriptine could also have the on and off phenomenon of Parkinson disease. As I said, basically is the symptoms of Parkinson um, could worsen or improve while on these medications. Now, in addition, you could use MAO inhibitors, which are selaglutine, aldopril, is basically responsible for degradation of dopamine. In addition, you could use anticholinergics. If you recall, we could use cogentin, we could use Artane, we could use Benadryl for patients that have EPS. So basically what they do is inhibit acetylcholine at the level of the postsynapses in the muscarinic receptors. So going back to the on and off phenomena, is important for you to know that Is a consequence of sustained levodopa treatment in patients with Parkinson's disease. Patients could have phases of immobility and incapacity associated with depression that alternates with improvement as well. Um, in addition, you could use catecholamine or methyl transferase inhibitors. Remember, this is the enzyme that breaks down the dopamine. So basically inhibits the degradation of dopamine at the level of the synapses. It does also have the on and on phenomenon. Eventually the duration of on stays become shorter, and wearing off happens sooner than when the person takes a dose of low levodopa. So again, remember, an on and on phenomenon is basically symptoms that could worsen or improve while the patient is on levodopa, carbidopa, but not only that is related to other pharmacological treatments that are given in patients with Parkinson's disease. So basically, all these medications, what they do is to restore dopamine at the level of the substantia nigra and improve the symptoms of Parkinson's disease. They do have a lot of interactions because of first pass effects, so um, you must monitor LFTs. You must monitor also the on and off phenomenon. Again, is for your exam, is a consequence of sustained levodopa treatment in patients with Parkinson's disease. Patients would have phases of immobility and incapacity associated with depression, alternate with improvement of symptoms. They're both pharmacokinetics and pharmacodynamic factors that are involved in this type of symptoms. The evidence is basically unknown. What happens is that there's redistribution of levodopa dosages, which may mean smaller or more frequent dosages or larger or less frequent increments that may be helpful in controlling oscillation in these patients. In addition, you could give dietary protein restriction to avoid the on and on phenomenon, but is invariably happens in many patients. So what do you need to monitor? Of course, the mini-mental examination, because many patients with Parkinson's disease will go into dementia. You have to monitor the signs and symptoms of withdrawal, signs and symptoms of anticholinergic effects, signs and symptoms of on and on phenomenon. Um, Remember that these medications could also give you serotonin syndrome, so you must monitor that. You must monitor for signs and symptoms of dopaminergic agonist, which it would be the psychosis mainly, as well as cardiovascular effects. Remember that these medications should not be combined with MAO inhibitors because it could produce a hypertensive crisis, and it should not be given with tyramine containing products as well. Amantadine could produce livedo reticularis. Livedo reticularis is mainly what you see on your skin when the patient has vasoconstriction, major vasoconstriction, mostly due to exposure to cold weather. So that kind of like cyanotic mottled skin when you're standing up for a long time or when you're exposed to cold weather that you see on your legs and in your arms is called livedo reticularis because of vasoconstrictive effect of dopamine. So monitor all the side effects that we already stated. Give low protein diet to avoid on and off phenomenon. In addition, you could avoid vitamin B6 as we explained before. Provide emotional support, provide adherence. Now let's talk briefly about insomnia. Insomnia is basically difficulty falling asleep or staying asleep, or in addition, it could be early awakening or sensation of unfreshing sleep. Now, you could also have excessive daytime sleepiness that patients could fall asleep during normal working hours or waking hours. So patients could have psychological dysfunction, at risk of depression, at risk of anxiety. They could also have medical conditions associated with poor sleep, such as high blood pressure, heart disease, diabetes, obstructive sleep apnea syndrome, immune system dysfunction, etc. You need an adequate sleep hygiene. So use the bed only for sleeping and sex. Avoid consumption of caffeine that could stimulate sympathomimetic activity before bedtime. Avoid exercising 4 to 6 hours before going to sleep. And try to get a regular sleep-wake schedule. Medications that could be used for insomnia are based on non-benzodiazepines or benzodiazepines, of course. And those are all control Schedule 4 medications, so we cannot prescribe that, nurse practitioners in Florida. So we do have Lunesta, Ambien, basically, or all GABA modulators. They're not benzodiazepine, but they modulate the same receptor, which is an inhibitory neurotransmitter. So they would enhance the GABA receptor activity. Okay, it's producing, of course, hypnosis and improving quality of sleep. In addition, you have Sonata, that it does interact the same way. It's also a muscle relaxant. It's also an anticonvulsant. You could use antihistamines to control sleep. That would be Benadryl, but remember, you have more anticholinergic effects, so you would have not only excessive daytime, but also you could have dryness. Antidepressants could be used as well for insomnias, but they're not the first line. Now, in addition, you could use benzodiazepines. You have short actings and you have intermediate and long acting. Try to use always short acting. Remember, short actings also are used for patients that have status epilepticus. So those are your diazepam, lorazepam. Even though you could use Xanax, you could use non or atypical benzodiazepines, which are Buspar. This is exactly how they work, basically enhancing GABA receptors. So all benzodiazepine, basically they work at the level of the GABA receptor, allowing chloride to exchange with sodium. That's the mechanism that they improve seizure activity, in addition to enhancing the inhibitory action of GABA. So they are used for anxiolytics. They're used as anticonvulsant, muscle relaxation, and sedation. Now, when patients have benzodiazepine overdose, that of course you could imagine what are the signs and symptoms. The antidote that is used would be flumazenil or romacicon. That what basically they do is they block the action of the benzodiazepine and antagonize the side effect of the central nervous system, avoiding lethargy, obtundation, and even coma and respiratory arrest due to uncontrol of the airway by major sedation at the level of the cortex and medulla. So of course the patient will be waking up. They would be waking up agitated and confused. Very, very short half-life. Now, we talked about anxiety. How do you best treat anxiety? Even though you could use benzodiazepine and non-benzodiazepine as a sedative hypnotic, you could also use tricyclics, which are not recommended first line would be again SSRIs. In addition, for anxiety and for insomnia, you could use, as we stated, lorazepam is even though it's best to use the short-acting to avoid excessive daytime sleepiness and drowsiness. You could use lorazepam Ativan, which is an intermediate and long-acting. For insomnia, you could use flurazepam Dalmane or temazepam Restoril, but again, you could also use serotonin anxiolytics, which Buspar is one of the best. Now, in addition, other second and third line treatment could be barbiturates as well as sedative hypnotics already discussed. So, for anxiolytics, you could use benzodiazepine, but remember the downside for benzodiazepine would be the excessive daytime sleepiness, the drowsiness. Patients cannot work in environmentals that have a hazard machinery. They need to be focused. They need to pay attention. So that would be decreased by benzodiazepine. So when this is the case, use always serotonergic anxiolytics, which are your SSRIs. You could use barbiturates. For hypnotics, if it's for insomnia purpose, it's best to use non-benzodiazepine or benzodiazepines. Now let's talk about Alzheimer's that we discussed in the first class. So let's touch briefly. Alzheimer's, remember that is the major cause of dementia worldwide. The theory that we discussed in class is related to the thought theory, the cholinergic theory as well. So basically it causes progressive cognitive deterioration characterized by amyloid deposits and neurofibril tangles in the cerebral cortex, and the gray matter as well is the most common cause of dementia. Basically 80% of dementia in the elderly is associated with Alzheimer's. Most cases are late onset, very highly confused with delirium, which is an acute onset. In addition, related to the pathophysiology, you have reduced level of acetylcholine and other various neurotransmitters, such as, for example, somatostatin is reduced as well. There's atrophy at the level of the cortex, mainly in the temporal and prefrontal cortex. As I told you, senile plaques are deposited, and as well as tangles. And this is the theory that we approached in class before, giving high levels of cell death. Patients with Alzheimer's, they have many stages: early, intermediate, and late. They have mainly cognitive deficits that progresses gradually. That's the key point related to in difference to delirium. That delirium is the acute onset. The patient was perfect yesterday and today is confused. Patients with Alzheimer's, they progressively have behavior disorders, agitation. They would have cognitive dysfunction, memory as well. The treatment generally is associated with cholinesterase inhibitors that we will discuss now. So this is the pathophysiology. And cholinesterase inhibitors, remember the pathophysiology is the deficit of acetylcholine, so you need to give more acetylcholine, and you could do this by cholinergic agonists or acetylcholinesterase inhibitors. So if you give, for example, donepezil that we already discussed in class, Aricept, which is your prototype, you basically inhibit acetylcholinesterase in the brain, giving more reuptake of acetylcholine at the level of the synapses, so having more acetylcholine. This also applies for neostigmine, that is the treatment for myasthenia gravis. So mainly side effects are associated with GI problems, um, basically nausea, vomiting, but the one that you must remember is hepatocellular damage. So you need to have a very strict control of LFTs. We already went over in class about the cholinergic crisis uh, versus myasthenia crisis, even though it doesn't apply to Alzheimer's. Having excessive amount of acetylcholine produces muscarinic effects. So that would be everything slow and everything wet. So having bradycardia, increased gastric secretion, uh, bladder outlet obstruction, bronchorrhea, bronchospasm, up to seizures, muscle cramps, fatigue. You would have meiosis, you would have bradycardia, and even arrest or blocks. You could also give a medication that improves levels of not only acetylcholine but also blocking the excitatory effects of glutamate, which is an excitatory neurotransmitter. That would be the N-methyl D-aspartate antagonist, which is Namenda. In addition, this could be given for patients that have ADHD or migraine, as well as patients that have neuropathic pain. Aldapril is another type of medication that is never the first line treatment. It's also a selective MAO inhibitor, so you already know the consequences of it, and is basically given when patients cannot tolerate the first line treatment, which is the acetylcholinesterase inhibitor, which is your amantadine, Namenda. Other agents that could be used would be ergoloid, that improves cognition in dementia. You could use N-acetylcyclogenase inhibitors. You could use estrogen replacement therapy. You could use statins to preserve cognitive function. You could use antipsychotics such as Haldol. You could use atypicals as well. You could use benzodiazepines and even antidepressants for patients that have dementia. So identify the difference between delirium and dementia, as well as signs and symptoms of depression. Avoid medications that could oversedate or block anticholinergic effects, such as over-the-counter medications and the one already discussed. You could also avoid polypharmacy, very high prevalent in patients that are elderly. Educate the caregivers on side effects, and also do mini mental examination, as we already discussed in prior classes for Alzheimer's. Always LFT, always beta-creatinine, avoid alcohol. In addition to medications, you must educate caregivers and go over environmental control support groups and also community resources for the caregivers. Now let's talk about mood stabilizers that is part of bipolar disorders and patients in manic phase, acute mania, or the depressive state of bipolar disorder. We could use mood stabilizers for bipolar disorders with evidence of depressive and manic or hypomanic episodes. If you remember, this is very important to understand many of the side effects. Lithium is a metal, is basically a cation that exchanges with sodium in presence of changes of water volume. So it has a very high water volume effect, so therefore decreased volume of distribution, if you remember. So very similar to seizure. It does have erratic firing in the limbic system and the frontal cortex. It does affect calcium channel, but also permits the influx of GABA. So lithium exchanges with sodium to be able to propel the nerve impulse along the cell membrane. So to be able to produce an actual potential, lithium exchanges with sodium. So any change in sodium, any change in water content of the body, meaning dehydration or volume overload, will affect the lithium level. Also, in addition, the only way of excretion of lithium will be the kidney. So it's very important to have a good renal function in order to prescribe lithium. So patients that have, again, do not forget this. Lithium has a very tight relationship with sodium and body fluid, and it has an inverse relationship with them. So if the patient has dehydration due to either burn or vomiting or diarrhea or diuretic use, the lithium level will be increased and it will be in toxic levels. On the contrary, if the patient is volume overload, the lithium level will be decreased. So lithium replaces sodium during depolarization, and that affects the transmission and electrical impulses. So patients could have cardiac arrhythmias. You need to adjust the dosage based on volume status as well as sodium status. And the indicators of toxicity would be tremors, vomiting and diarrhea, polydipsia and polyuria, so mainly associated with water balance. So patient would have a lot of diarrhea, confusion, stupor, polydipsia, polyuria, up to ataxia. And you must monitor the patient for cardiac arrhythmias. Very, very important. Has a very, very narrow therapeutic effect. 0.6 to 1.5. It doesn't bypass the liver, so has no protein binding, no cytochrome P450 interaction. But what does have is a very narrow therapeutic effect, and you must monitor sodium intake, salt intake, and water. Do not forget that. Now, another medications that could be used as mood stabilizer that was already approached in seizures is valproic acid. So basically, valproic acid blocks GABA uptake at the level of the presynapses without affecting the benzodiazepine binding site. So it slows repolarization, also reduces glutamate function, affects also sodium and calcium level. There's also toxicity associated with valproic acid, and that is related to bradycardia, drowsiness, up to respiratory depression and coma. As many other anti-seizure medication, even though we are talking in this slide about mood stabilizer, remember that impairs platelet aggregation, even though it's rare, hepatotoxicity. It could produce GI distress, CNS depression. Now let's talk briefly about attention deficit disorder. That's one of the last topics. It's also called ADHD, which is hyperactivity disorder, and it's basically poor short attention span and excessive activity of impulsiveness in a child and in an adult as well. So it's a brain disorder that could be present from birth. Some children mainly have difficult sustaining attention and concentration, and they're labeled as lazy and in class. Some children are overactive and impulsive. So basically there is criteria that is associated with it. Any unsustained attention, lack of concentration, inability to finish a task, having impulsive disorders, talking impulsively, forgetfulness, disorganized, inattentive, distracted. That will allow treatment for ADHD. Now, talking about treatment for ADHD, the first choice treatment will be the stimulants. Now, the downside of the stimulants would be since they have sympathomimetic activity and they act at the level of the dopamine, agonizing dopamine, preventing reuptake of dopamine, serotonin, and norepinephrine at the level of the presynaptic nerve ending, they major adverse effect would be heart disease, hypertension, hyperthyroidism, because again, they sensitize sympathomimetic amines. So they would have hypertension, tachycardia, and cardiovascular disorders. Can't forget that. You have to start with a low dose. Your prototype will be your methylphenidate, which is Ritalin Concerta, even though you could use amphetamines such as Adderall. And as I told you, basically you will be increasing the levels of these catecholamines, which is epinephrine, norepinephrine, dopamine, at the level of the cerebral cortex. Having wish manifestations, headache, insomnia, up to seizures, up to stroke and MI, up to sudden cardiac death, even priapism. You could also use amphetamine, as we already mentioned, having more or less the same side effects. Non-stimulant medications that could be used, atomoxetine, which is only approved for adults that have ADHD. This is not only the child grows into an adult person. It's exactly the same mechanism of action, inhibits the reuptake of epinephrine and norepinephrine. And the contraindication, again, is patients with cardiovascular disorders. Patients cannot take these medications with another stimulant or another medication that could increase the reuptake of norepinephrine, which one of them is monoamine oxidase inhibitors, and not even in narrow angular glaucoma, because you would have nicotinic effects. So you have to monitor for hypertension, tachycardia, abdominal pain, headache, and even EKG, because it could lead to tachyarrhythmias and sudden cardiac death. You must monitor a liver function test. It has a very high first pass effect, and blood pressure and vital signs. What else can you use for ADHD? We already talked in alpha 2 agonist, the off-label treatment for ADHD with clonidine. And you already remember that the major side effects will be hypotension, mostly orthostatic hypotension, and also retention of water, edema. That's the reason why you should use it with diuretics. So this is the major side effects that you must control: vital signs, EKG, and in the child as well, of course, growth and development. And we're not going to discuss opioids because it will be discussed next class in headaches. So this will be the end of this topic.